Thanks, Sarah. I feel a bit like Daniel in the lion's den. Yeah. Tēnā koutou. Ko whita rea te monga, ko raukaua, te moana, no paramata ahau. He rata ahau. Ko te tumu whakarai o te whare tohu rata o Aotearoa ahau. He mihi nui, tēnei, kia koutou. E pai ana, e tau ana. Nō reira, tēnā koutou, tēnā tātou katoa. I'm one of probably the few true Wellingtonians, born here, grew up here, spent 4 years away in Otago and came back here. Most Wellingtonians just leave. It's too windy. I class it as permanent CPAP, so yeah. I'll explain the slideshow. It is just pictures only because there's not many GPs in the room, so I thought I'd bring them with me. As Murton says, it's hard to engage clinicians when you want them to do something, so I've put out several calls for photos. So you'll see some repeats because there weren't enough pictures. And the other thing is, if you only have pictures, you don't have to worry about spell check, so there'll be no keen replacements, Murton, and no effluent countries. So enjoy the slides. Yeah. I'd like to see how many GPs there are in the room. I think there's about 5 of us. Hands up. Oh, nearly 6. Awesome. Oh, there's one down the back. Hey. And how many of you have a GP? Yeah, good. Awesome. And how many love your GP? Great. How many have been rude about GPs? Come on, be honest. Yeah. I remember working in ED when I was a general practitioner. Oh no, I wasn't. I was a surgical registrar. My card had red shoes because I used to wear red shoes all the time. And they put it up. But I remember standing there going like, I'd never be a GP. You have to know too much. And that is the truth. We do know an awful lot about various types of medical things, about lots and lots of patients. And we also know a lot about our community and where we work and what our community is like. My background is, yes, I was an Otago graduate. I worked at Wellington DHB. Who said they didn't ever come back here? I know what it was like, yeah. Night float, 1 person on, 450 bed hospital, terrifying. I think my worst night was when the man I had been dealing with all night finally smashed the window and climbed out on the parapet, and they rang me and said, would you like to come and see him? And I was going, what am I going to do? So he was marching up and down with his drip pole saying, get me the police. And I did, yeah. Yeah. So after having done lots of surgical training, I eventually helped us start the practice that I work in now, and that was 20 years ago, and that just sounds really scary because I did surgical training for a long time before then. So I say that I started training at 12, so I'm not really as old as I look. Yeah, or I am older than I look probably. But I think, general practice, I have loved every minute of what I do. I'm going to start off just talking a little bit about the background of where general practice fits in the public health system, and I know people say, well, it's privately funded, but by the end of this talk, you'll have a different thought, I hope. I want to look at the current state of primary care, the areas I believe need changing in order to lift the standards of care where we're able to provide for our patients. And I'm confident there are alternatives to the current system which would help improve access to health care and the quality of care currently available. The college also put a submission into the Health and Disability Review, and I'll talk a little bit about that as well. Aside from my current role, as Sarah said, I have been in medical education for a long time, and I've worked with the college. I've spent a lot of time with junior doctors and registrars training, and a lot of the medical students, and go medical students in the room, awesome. But we have lots of conversations about medical students really not spending enough time out in general practice, and the week in 4th year, maybe a week or not any time in 5th year. The ones who are the lucky ones who spend a year in general practice as their RMIP run, amazing time for them, and also they are around a general practice and their marks are better at the end of that year. So the 5th year exam marks for these guys are higher than they are for people who don't spend time in general practice over that year. So the more we can get students out into general practice, the better it would be. General practitioners play a significant and well-respected role, I hope, in the public health system. We're the most commonly seen medical professional, despite your pharmacist being the one you see most often. We see 12 million consultations each year, and that's 5,000 of us. It's averaging 3 to 4 visits for every Kiwi. The publicly funded hospital discharges, by comparison, are roughly 1 million. So I do 12 times, or not me personally, but as a general practice, we do 12 times the discharges that come out of hospital. One of the key skills of a GP is to able to manage a massive amount of uncertainty, and each day we come across a huge range of undiagnosed medical issues, and we manage the influx effectively. We work out what's wrong and what's going on for them, arrange the tests, not just down the corridor. We follow up and we provide or arrange treatment within the confines of a public system, and we guard the public system really well. We're very careful about our prescribing, we're very careful about what tests we're ordered, and we're constrained with what tests we can order. I can't order an ultrasound scan for anyone and have it for free. It has to be for certain conditions only. So if my patients need to have scans or things that they don't fit the criteria for, then they will need to pay. If I wouldn't say this, but if I scam the system and put them through for a form that actually says that they can get some funding for their scans, because all my patients in my practice are hard up mostly, I eventually may get a conversation with one of the people from the PHO, who's funded by the District Health Board, saying, oh, you're overspending. So I'm very constrained in what I can do and how I make things happen for my patients. There's a plethora of research showing that money spent in primary care, as Otmar says, results in reduced costs and improved efficiency in secondary and tertiary care, and garnering better outcomes for patients and freeing secondary and tertiary care to do what you guys do best. You do that high-end stuff. And although we talk about, creaming off the top and the cherry on the top, as far as I've had conversations with dermatologists saying you shouldn't be doing minor surgery in general practice because it's taking away the easy things. And you go, well, my pharmacy down the road is taking my flu vaccines and my throat swabs and my urine tests, but actually they're not my urine tests, they're convenience for a patient. The higher level of skills that you guys have in tertiary and secondary care and the things that you need to provide in ICU or cardiology or wherever it happens to be, which are at that higher level than they ever used to be, now means that that's a flow-down effect to me. I do knee joint injections, which a lot of people wouldn't have done a long time ago. We used to have hypertension clinics in the hospital. That would just be ridiculous nowadays if I sent someone and said, oh, their blood pressure's a bit high. Yeah. Imagine that rejection letter. Get a grip. Yeah. So, we do a lot of work that would normally have been in the hospital, and now it isn't. We play an indispensable role in provision of preventative care and health education for our New Zealanders. It's actually really hard to do a lot of this education when a patient just turns up randomly and you are dealing with whatever their need is, and then you're expected to do all these other things as well. But we continue to do them with our staff that support us. Educating public health issues about giving them the knowledge and understanding to prevent avoidable conditions is invaluable. When my patient presents, I spend a lot of time working out if they have a cell phone, to getting the cell phone number correct, because often that changes, changing their address. I've been doing some research, and one of the videos that I looked at was this chap who was seeing his diabetes nurse, and he was sitting on the chair, leaning back, and he said to this nurse, he goes, oh, that dietitian, she never came to see me. And so she was chatting away and doing a few things, and he goes, it might have been because I've changed houses 4 times. And so eventually he acquiesced that he was actually very hard to get hold of, and that's the nature for a lot of our patients, that they are tricky to get hold of. And if you talk to anyone, getting a new cell phone number from them is one of the most critical things. It's also important to note that GPs are continuously upskilling and adding to their toolbox. Many of my members have completed further postgraduate training in additional specialties. In my work, I've got a GP who's advanced in travel medicine. I do a lot of minor surgery myself. I've got another who's doing gynae procedures, and we're all involved in education. Our nurses are skilled in diabetes and mental health. I know of GPs who are training in endoscopy, ultrasound scanning, and ENT. All of this is expanding the services that can be provided in primary care, and therefore allow us to take on the stuff that is now being sent out of hospitals. And I mean, that's okay, but we need to have the support and the space and the ability to be able to do this. The New Zealand primary care system is quite unique. We do have this private-public partnership in primary care, and while it's true that general practices receive some funding from the government to subsidise their fees, practice owners must also invest their own money into their practices and as such have to charge patients just to make ends meet. Since the early 2000s, capitated government funding has been funnelled down to general practices through the district health boards and primary healthcare organisations. And I sort of align it to, like that big river that comes down through the gorge. It looks massive, it's amazing, and then it goes out into those alluvial fields and you have these little trickles that go past. And so in general practice, a lot of the time, I think we feel like we're digging in the gravel looking for the water. Our practice owners do set their own fees, but these are significantly restricted. A case in point, my practice that I work in, I had a fee that was something like $28 when capitation came in, and they said, what's your fee going to be? And I said, well, it's $28. So that's fine, but I am only allowed to increase my fee by 1.4% per annum. And so if I don't do it one year, I can't do it the next. So I can't do 2.8% the next year, I can only do 1.4. So if I have started at 28 and I'm increasing by 1.4 per annum, I'm never, ever going to catch up with the guy who started at 50. And the guy who started at 50 will exponentially increase his fees, and I will continue to sort of creep along at this bottom level. And as compliance costs go up, nursing MECA rates go up, and all those other things, the thing that gets lost, because my fees for my computers are higher, my accommodation is higher, where does that money come from? It doesn't come from my patients, it comes from my pay packet. My practice turnover is I think it's half an anaesthetic machine. How much was the anaesthetic machine? Was it $2 million? 100,000. Oh, 100,000. Oh, okay. 10 anaesthetic machines per machine, yeah. So, I mean, that's the thing. I mean, I'm only 10 anaesthetic machines. Ultimately, it means that many general practice owners are very limited in the current funding model, and for some practices like mine, which sees the low income and high needs patients, it can be a struggle to keep an appointment cost low enough that patients will come in, and I can't put them up anyway, so it makes it very tricky. If I look at my budget for this year, 70% of my income comes from capitation. Don't tell me I'm not a public service. There are many practices like mine, and in a recent survey of practices completed by Otago University, the average practice has 3 full-time equivalents, like mine, has 3 nurses, I don't have that many, and has 5 to 7 rooms. We serve 4,500 to 6,000 patients in most of those types of practices, and in small towns, that's the whole population. So those small practices that are running at that level that is actually hard to keep going, they are serving a lot of our smaller communities, and we don't have the benefit of a 12,000 person practice that gives you capacity to have a bit of space to do things. There's a huge difference. So what do I get paid? Like this, we never talk about salaries, do we? But we will now. I'm a girl, I can talk about money. So the difference between publicly funded doctors, I think it's funny that, this is a district health board, and under the district health board, the hospital doctors get paid on a MECA, which is through the ASMS. Now, district health board gives me money as well. So how does that rate with my salary, and where do I come up? My salary or my fees that I get has to purchase my equipment, my room, my rent, employ all my staff, meet my compliance costs, and there's no contact time, no contact time. So if I don't see a patient, I don't get that extra 30%. I don't have to pay for my own super scheme, my KiwiSaver, my holidays, and cover the costs of continuing professional development. So who paid to come here today? Okay. If it was our conference, a GP conference, all of us would have paid, okay? We found in a recent survey for the college conference, we found GPs are earning considerably less than their hospital doctors, whose funding is provided directly by the DHB. The last survey showed that the average GP salary was $157,000 a year. If I wanted to increase that to the MECA, to the rate that I should be on for the number of years that I have worked, I'd have to find an extra $60,000 a year. Now, with my 1,000 patients that I look after, that's another $20 every time I see them. And if I wanted to do that, I'd have to go to the DHB and ask them if I'm allowed to increase my fee. And because it's more than 20%, they'd say no. And I can guarantee that. If I put it at 10%, the funding planning guys will go like, ooh, no, that's a bit squeaky. I don't think we can do that. So it's actually very difficult for us to make differences and be nimble and have enough flex in the system to be able to change the services that we provide within the current model that we have. I think it gets most GPs goats, and if you could just go away from this and say, I now see that primary care is a public service, that would be really helpful, because all of us are constrained by the public fund that we have, and although we do have some private money and people do spend money in our services, it's a very limited part of what we work from. A report by Don Matheson, it was several years ago, and I think he sort of got slammed for it, but it said that if you took 1% out of the hospital, of the funding to the hospital, it would increase the primary care funding by 10%. I can't wait. Yeah. With the right funding, for example, general practice would be able to provide more acute care, employ other allied health staff, expand our services delivered, and have time to better manage the complex illnesses we deal with. I know that they talk about nurse practitioners, but a lot of their roles, they would want to have 30 minutes with a patient. I can't afford to have 30 minutes with a patient. There's no funding for that. I was thinking about, do we actually relate to the DHB and how do we fit in? And if you look at the DHB performance measures, I had a quick review just yesterday, and I looked at the 2019 measures, of which there are 44, and 30 of them are directly attributable to primary care. I know a few years ago we got this really glossy, beautiful... Is anyone from CCDHB here? I'll say it anyway. I got this really glossy document in my waiting room that said, look how marvellous CCDHB is and how wonderfully we've done, and isn't it just great? And every parameter that they were talking about was things that primary care had done. It was about the immunisation rates, it was about the patient satisfaction surveys that we put out. It just had everything that had come from primary care that they're saying the DHB is just a marvel. So in my practice, so on my 10-hour day on Tuesday, I'd like to tell you how I improved the performance measures for the local DHB. I rang the mum who has dental caries. I was in the office while my nurse immunised several children. I caught one of my Maori patients who was overdue for her smear. I supported 3 people to quit smoking. I reassured my other mother that her kid was actually healthy and it would be fine. I provided medication to several diabetics, hypertensives, depressed and anxious people. I supported further counselling to one. I discovered cardiovascular risk in another. I discussed how to get breast screening with another while encouraging her to get into work. I removed a lesion from someone's head, made sure the addresses, phone numbers and NHIs are up to date, went to a meeting about a new building, and I'd really love to have some of that 1.7 billion capitation funding or capital expenditure funding to do that. So I'll go back to the DHB and ask them for a little bit of money for my building. I smiled and put on a brave face when my colleague announced she was moving town. And then I reviewed all my other colleagues who are on leave and looked at all their labs that they had. So yeah, it was a busy day. And also, I was double dosing myself on antibiotics for my dog bite. I thought it would be worse by today, but it's actually better, fortunately, because otherwise I would have been one of those primary options for acute care people who would be sitting on a drip while I was doing my working while unwell. As far as ASH rates go, I get a list, and then I have to go through my list and say, how many patients on there can I prevent from going into hospital? My favourite one recently was a 48-year-old, and I hope no relation of his is in the room. He is just gorgeous, but he's slightly pudgy around the middle. And he comes in and he goes, I only smoke one cigarette a day. And it is my vice. And I said, it's not a good vice to have. And he goes, oh, no, it'll be fine. And so the other week he came and I said, I've got this list and it's got all my people who are at risk of going to hospital. And I said, you are on my list. And he goes, why am I on your list? And I said, because you're slightly pudgy around the middle and you smoke that one cigarette a day. And he goes, I don't like being on your list. And I said, no, I don't like you being on my list either. So it was actually a really good thing. So we had a good conversation about him quitting smoking and actually eating the vegetables that his mother encouraged him to eat. I think that, we all know the health system is under relentless pressure both in and out of the hospital, and an ever-increasing demand for care, and without significant changes it may reach a breaking point. You may not be aware that, but 47% of these GPs, not the young ones, but of my colleagues, are going to retire in the next 10 years, and 27% in the next 5. I was one of those group in Murton's graph that had the sort of like the whole of no investment in healthcare for the 1990s, and so over that time we trained 50 GPs a year, and I'm one of them, and there's a few of us around the room, but actually all my colleagues who are 10 years ahead of me, they're all going to retire, and the few of us that are left are going to be holding the fort until the 30-year-olds come through and start doing the job that we've been doing after they've had all their children. So I think I'm going to be working till I'm 90. We had a survey that 11% of GPs currently are working over the age of 65. So over 65 is 11%, and in the general workforce that's 6.5%. So as doctors we do work longer, as GPs we're way out there. On our health and disability submission, one of the practices wrote to us, and this is the same as a part of a small Maori health clinic which is part of a wider Māori health organisation. Our clinic liaises closely with its own pool of community and social services. Many of these are free for patients, which improves access. The clinic and doctors prioritise patient care above many of the fiscal constraints we work within, meaning we often run our consultations overtime, often offer free appointments, especially follow-ups, often stay late, and the clinic struggles to make ends meet. I'm not sure how sustainable our clinic is in the long term. I could go on and talk about equity, I could talk about integration, there's all sorts of things that would be really helpful, and we've put all of those as a college into the Health and Disability Services Review. There's lots of stuff that my colleagues would say, please be better with GP to follow up. Just consider the GP who's following that up. Think about it as your own GP and think, well, what would I want? What would I say to them? Because it actually makes it really hard when we're hunting down results that haven't integrated into our system really easily. It's really hard when patients go into hospital and say, oh, you'll be back in hospital, and no one supports them being back out in the community, and that's what my job is. So just think of your own personal GP when you are saying GP to follow up, and I think remember that we are a key and critical part of the public health system, and we see 12 times what goes into a hospital. Thanks very much.
Thank you, Dr. Murton. All these things I am learning very quickly in the last 3 years, and I am one of those 30-year-olds who needs to get through the family before she becomes you, but I'll do it quickly. We have our panel discussion next. We have Dr. Siobhan Cross from ASMS Canterbury Branch Vice President and Paediatrician at Canterbury DHB. Dr. Sylvia Boyes. Oh, here we go, sorry. ASMS Counties Manukau Branch President and Emergency Physician at Counties Manukau DHB. And Fraser Jeffrey, President of the New Zealand Medical Students Association. Excellent. Who would like to start introductions?
Sylvia would.
Sylvia would, great.
Somehow I have a reputation for not being shy and just speaking out. So yes, I'll start. A few notes I've made. Look, I agree that general practice is our primary health, is core to healthcare overall in the public health system, and that general practice is essential to that. How do we help you with sustainability of general practice? How do we help young people to consider general practice when they're predominantly training within a hospital environment? And also, how do we support you with the increasing requirements for increasingly comorbid, complex care that's being divulged to general practice in order to free up our hospital bed spaces, which is an increasingly limited resource of itself?
Yeah.
I think, I felt quite brave standing up here, so I think actually the whole health system has to be brave. I think we need to really think about where we fund money, and if we say that we're not spending enough on health, then actually we need to step up and spend it. And from a DHB point of view, you have to remember that we are a health board, not a hospital board, and if we can have more of our colleagues out with us in general practice, that would be ideal. I have a psychiatrist who comes into my practice once every couple of months. It is just awesome. And we spend time talking about patients. I don't now refer 10 patients to him every couple of months because we talk about them in one session for an hour. And there's lots of ways that we can change the way we run stuff, but also I think the funding needs to just be beefed up. I pay for my own social worker. If a social worker was funded for me, that would be way better. Yeah.
So I'm Siobhan Cross. I'm a paediatric haematologist oncologist, so I'm the opposite of a GP who knows a little about everything. I know a lot about very little. I also hate uncertainty. I spend money like water within my clinical practice at least, and maybe my shoe collection. And a couple of things that I sort of was reflecting on in my practice and with your talk. One is a meeting that I was at a week ago on a video conference where we were talking about surveillance. In this particular case, it was the ongoing surveillance of people who have familial cancer predisposition syndromes. But that surveillance goes across many areas. And these surveillance things that are becoming more and more prevalent as there's more evidence for them, I'm going to ask the question that I probably know the answer to, that there's no funding stream that comes with that transfer of workload if the surveillance clinic then becomes something that's devolved to the GP practice.
No. So if I am looking after my recall systems for people who need colonoscopies because of the familial stuff, that is just something that my nurse does all the time. If I have people who have had care started in a DHB and they said, oh, well, your nurse could do that at the practice, there is no funding for that. It doesn't come in. So if we're looking after the coagulation clinics and the hospitals are slowly having a slow demise, I think, and we as GPs spend our time looking after those, we have to charge a patient. We don't get any money that comes from that. If you're going to do a steroid injection, it's a cost to the patient because orthopaedics won't receive a patient unless they've had a steroid injection in my area, and so therefore I have to do that and it's a cost to the patient. Yeah.
Kia ora. My name's Fraser. I'm the president of the New Zealand Medical Students Association this year. I'm also a trainee intern from the University of Otago based out of Christchurch. And I was reflecting on my own experiences in general practice throughout my training. I had about 8 weeks in fourth year with about 3 GP clinics in the afternoon a week. And then this year I spent 3.5 weeks in a rural general practice in Akaroa off the peninsula from Christchurch. And even in that short 3.5 weeks time this year, it really struck me how isolating particularly rural general practice can be. The 2 GPs that work there, they work part-time, they work 3 days a week, and they've tried to live in the community, but they've actually have their families based out in Christchurch and then commute in for 2 nights throughout the week. So to me, that kind of showed that rural general practice is a big challenge, and I think you've highlighted throughout the college's work how big of an issue rural general practice can be. And as a medical student, it needs to be seen as an attractive career option, and there needs to be adequate support around general practices in those areas, because the burden on those GPs can be large. And we've heard a lot today about job satisfaction and burnout. And if you don't feel like you've got that job satisfaction in those isolated communities, then you're never going to work there. And for someone like me, that's a big barrier. So I think that's an area that's going to need to have a lot of work.
With the college has the Rural Hospital Medicine Training Program as well, and they are doctors who are working in the smaller hospitals, and the training program can be done alongside general practice. I think having that support of a rural hospital for a lot of people, and I know that a lot of the specialists in the DHBs are supporting people who are in rural hospitals who are providing care, and I can't value you enough for that support that you provide. All of my colleagues who are in rural hospital medicines love the fact that they can ring up and the surgeons or whoever they talk to are really grateful and helpful and look after them. I had a conversation just the other day with someone, and this is what support is. And she said that she had noticed that the people who are doing surgery who had done their respect training treated her differently from what they used to. So go the surgeons. That's really amazing. Yeah.
All right. Do we have questions from the floor?
Hello, I'm Dr. Mark van der Waard from Wanganui. I just want to support your comment about specialists working in GP practice. I'm a psychiatrist, and I just started doing weekly clinics in the GP practice, mainly to help those clients that don't go and see their GP. So they get a checkup, just the bloods and everything, but stuff they haven't had in 2-3 years. And I would say, and then we do a monthly peer review with all the GPs. And then if GPs need to talk about anybody, even if I've seen them or not, they can call me anytime. And I would say that's cut down my referrals by 50-60%. Yeah. So it's amazing. It's just a conversation. And then I educate them about what I consider as a proper referral as well. So I'm pretty... They understand not to send me, minor stuff.
Don't send the trash.
Yeah, and what I think needs to happen, I don't know, I'm not sure how this works, but I don't know why there's no clinical psychologists in general, in primary care. I don't know, is there?
No,
but not where we are.
No.
And, half the people get referred to us, they want to see the psychologist, and it takes so long for them to get there. And it just doesn't happen. I don't know why they don't put psychologists into primary care.
Well, that's the hope with the mental health funding that's come through, that would be something that would be common now. And that you can... I've got a counsellor who is in my practice, but she's privately funded, but at a lowest cost that she possibly can. But once that's funded in, it makes it a whole lot easier. My patients are much happier to feel like they're going to the GP practice rather than going to the psychological clinic. So if they can come into my office and see someone, no one knows that they've seen the psychologist. They've just gone to the doctor, and that's much safer for them. So, yeah, hopefully that will come with the new funding that's come through, which is just awesome from our perspective, yeah.
Hi, Ian Page, gynaecologist. I was lucky enough to do a couple of years in general practice before moving into a specialty, and it's made a huge difference. But even as a medical student way back then, people were saying that we should be spending far more time in general practice as students. Why do you think that's not happened?
I should get Ben to answer this. He and I had a rant about it earlier on today. But it's just, if there's any space in a week comes up in the medical training for students, the number of voices around the table who are psychiatrists, surgeons, medicine people, orthopaedics, whatever else it is way louder than the voice of a general practitioner, because they're not actually probably in the room. There's not many very GPs on that committees. And if you've got any mates who are involved in the training, then tell them to say, let's give it to general practice, it'll be much better. My 4th year student I had with me a few weeks ago, I said, what if you did all your training with me? And he goes, that would be amazing, because they get to do stuff. We're quite happy for them to see patients, and it is really good training. And as surgeons, physicians, psychiatrists, whoever else you happen to be, having students who are well trained because they've done lots of stuff will be way better for your own profession. Yeah.
Thank you very much for your really lovely talk. I did general practice many years ago in Scotland, and I realised that you had to be very, really, really clever and jack of all trades. So I ended up in at the blunt end of medicine and genetics, and emigrated here, and have great respect still, and all my pals are GPs. I'm going to play the devil's advocate. I've come to this meeting a couple of times, and the ASMS is our union. It fights very hard for our salaries, it fights very hard for our CME. We're also very aware in this country of inequity, and it's getting worse. And we are contributing to that, not the general practitioners, but the medical specialists. Perhaps to keep things cost neutral, we should think about moving some of our really very generous CME, which I have loved using, but now worry about my carbon footprint when I go to Europe for genetic meetings. Perhaps we should shift some of it from our hospital world into the general practice. Yes. And perhaps our salaries as well.
Yeah. I think it gets everyone's craw talking about the fact that you guys get so much CME money and we get Zippo. It just drives us mad. So, yeah, if anyone was feeling generous, general practice would be really pleased to have your CME money.
What is your union, or do you have a union, or is that your problem?
Very good question.
Oh, kia ora, Annie Judkins, GP, for 12 years at Newtown Union. That got a bit too easy, so I went out to East Porirua. Now there for 5 years. I've been a member of ASMS for all that time. Had Angela first with my back, but now my mate Lloyd comes to many of my meetings. So if you've ever get in trouble, go to ASMS. So they're our union. That's who we go to. So if we're as a salaried GP, I've been salaried all that time. Who fights for my salary? It's Lloyd. Who fights for my $3,000 a year CME? Lloyd.
Yeah.
Oh, yeah. God, I'm going to be here another hour. No, what was the question I was going to...
The question is, who's our union? I think the other thing is that there's a lot of GPs from the past, like all my GPs who are the 10 years older than me, often they have gone out into general practice, they're privately owned, self-employed, they may have other roles, and so having a union's not really easy. Mm-hmm. And whereas my colleagues who are coming through, a lot of them are employed, so that unionist stuff will start to come through with time. With the PHOs. But then, is the government going to be able to fund the fact that we now are wanting a level playing field? Mm-hmm. And that's an interesting question.
Yeah. I mean, and even if the playing field doesn't start off level, at least if it starts making steps in the direction of some CME days is going to be better than no CME days. Yeah. Because when you're getting paid per capita, not only are you not getting paid when you go to CME, but you're also losing money because you're not seeing a patient each day. So your 28, all of that money is not there.
Yeah.
Now she's going to say what I came here to say. With regards to primary-secondary interface, I've been running clinics which have had secondary interface since I went into primary care. First one I set up for myself was Child Development Clinic, because the CEO of the DHB said, what can we do for you that will help your community that will cost us nothing? So so that's the model we start from in primary care. If you're going to do good for high needs practice, you start with, you will have no money, how can you spend it wisely? So what we did was set up a clinic quarterly where I got the paediatrician in, I got the patients in, I wrote all the letters, we did all the referrals, but the patients turned up. We've done it with eczema, we've done it with diabetes, we've done it with psychiatry, we've done it with mental health, I've done it with maternity care. So I'm going to give this back to you, most of you secondary care people. Come to us. Ask us what you can do for us, because we can do what we do a whole lot better with your assistance on our floor. Our patients coming to you doesn't work that well. They don't understand, they get confused, they come back to us. We then charge them nothing to translate what you've told them. So we make no money. Just because we're not for profit, we shouldn't be losing as much money as we lose. So I've always worked not for profit. If you guys come to us, we can get a much better public health care system. But if we keep sending our patients to you, it's not going to improve. Kia ora.
Could I take panellists' rights and just interrupt? I'd really appreciate you talking about the role of the accident and medical clinics, and they're also taking capitation fundings for providing services, but certainly what I see through ED is that their patients are not getting the same continuity of care, the same follow-up, the same active management of chronic conditions, and their health outcomes are much worse. And are you happy to speak on what may not be a PC subject?
I think, accident and medical clinics across the country are very different. There's this particular flavour in Auckland which is quite different from elsewhere. And I think the trickiness is that there's sort of a monster that's been created by ACC, which in some ways, and the services that they provide can be very ad hoc, and if they are providing care that's about accidents, they'll go to that first, then they'll provide the chronic care. I know at our clinic here, which we run by as GPs, it's not actually a separate service run by a group of doctors who just run it. Our one is run here by different GPs going in and covering the service, and so it's a very different ballgame. We know that those patients are going to go back out to us, and so they're not actually capitated in here. So it's very different around the country. I know that it's actually skewed in a quirk of Auckland that they are specific standalone clinics that actually have a capitation fund to them, which does make it very difficult when their primary driver and income is through an ACC service, which isn't about chronic care. Yeah.
Sam, thanks. I found your talk most enlightening. David Jones, retired physician. The question is a simple one. It has been sort of touched on, but what are your views, the college's views, but also your colleagues' views on general practice becoming a salaried position? I
think it's an interesting beast, really. There's been a conversation going on around that with our GP Leaders Forum, and whether there'd be an appetite for it or not. I think GPs from yesteryear went out into general practice and had a business that they ran by themselves, and they had autonomy, and they could do what they wanted to, and they could be creative, and they were in the community, and if money came in, it might be potatoes or a chicken, but like if money came in, they could spend it on how they wanted to as far as care goes. As we've been corralled, the money there's restrictions around funding and what we can do with the funding, and there's stuff that we need to achieve to meet the DHB performance measures. It's made it much less autonomous, and I think in some ways we're being driven in that direction. A lot of our younger doctors are employed because employment feels safe. Some of them are happy to become partners and buy into practices, but there's a lot of practices that are being bought up by big consortiums because there's no one who's brave enough to put their money into it, and it's actually your own money that you're putting in. And as a young doctor, would I be putting my money in when I have a student loan of $200,000, I have a house that I have to buy that's going to cost me way more than it used to cost me, and I'm having kids at the same time. You're sort of hiding to nothing. When I first worked having kids, and my husband was working as well, but actually my income that I earned paid my taxes, and then the rest of it went to pay for my childcare, and pay the tax for my childcare and the ACC fees for my carer, so that my kids got good care, and I could then provide the best care to my patients. So my patients got the best of me because I could be told off for being a bad mother, but I could be struck off for being a bad doctor. So I think it's actually, there's lots of perverse drivers that are heading us in a direction that may end up in salary. That's the way it's going to be. We can fight it, and I think there'll be a lot that will fight it. And I think from a perspective of general practice and for the patient, having big consortiums owning general practice or turning into the NHS, it's just not going to be good for patients.
Tēnā koutou, my name's Mark Peterson, I'm a GP, I'm a self-employed GP. I'm also a member of ASMS, which is a little bit strange, but I also have a DHB role for which that covers. And I guess we talked about workforce and encouraging people into primary care, and at the moment there are lots of disincentives for people to go into primary care. And I guess I have a challenge for ASMS that actually for Sarah and Annie, who are ASMS members, the salary package that you've negotiated on their behalf is less than you've negotiated for them would they be hospital specialists. Annie gets $3,000 professional development. You people who work full-time get $16,000. Is that fair?
I don't think there's anyone on the panel that'll be able to answer that one.
No. The other thing is, I was going to say, the students coming through. We've got 247 applicants come into general practice or applied for general practice this year. So there's good interest, which is great, but we need to make a service that's really good for those guys to carry on working in, because they need to carry on working in it. Yeah. Ben?
Hi, my name's Ben. Oh, that's really loud. I'm one of the other medical students at the conference. I sit on the NZMSA and a new organisation called Students of Rural Health Aotearoa. So full disclosure before I make this comment, I am from a rural background, and probably I'm one of the few people in this room that is from a rural background, which is quite sad. I have concern that general practice is the primary interface with which patients interact with the health system. We have increasing levels of GPs coming towards retirement, and they also appear to have the worst shortages of workforce, and all of the responsibility, or the majority of the responsibility to fix those workforce issues is being placed on GPs. So GPs are being asked to take more students, more registrars, without decent funding to flow through with those things. And while a lot of GPs are really generous and really giving with their time and keen to help the position of the future general practice workforce, it strikes me that they, like hospital specialists, have increasing levels of burnout, and it just seems scary. And I'd like your comments on what we can do to prevent this wave of burnout that's coming from this wave of retirement that's going to create the shortages in our workforce that's going to affect the health of communities, particularly rural communities, who will be hit first by that retirement wave.
Yeah, I know our rural guys really struggle, and I think it's the support in rural to have extra other staff around you. Sometimes it's the other staff around you that make the big difference. The support from the DHBs and from the hospitals to be able to say, like, I can back you and I can look after you and I can guide you through video conferencing is really awesome. But our capitation funding for general practice has been very constrained for a long time. There hasn't been a lot of extra allied health professional fund going into that. We get some support through long-term condition management, but I think the basic model needs to be busted up, because capitation, the way it started was, what year was it, Mark? 2001, 2002, something like that. So that's like, 18 years old, and it's exactly the same as it was then, and it's moved a little, but it's only moved a little. And so that whole foundation of if you're going to have comprehensive healthcare and you want good money to go into the place where it's going to have the biggest bang for your buck, you guys will have a much better job if we can do a much better job. And so although there has been sort of like, primary care is not the solution to everything, I think primary care needs to have it needs to look like a wedding cake. The funding needs to have a really good big foundation, so that then the other tier stuff on top, the secondary and tertiary, can do what they need to do, but there's a really good foundation for providing that support. And if you're at my mini hospital, which is my practice, if you come to me, then that would be great, because then there's a lot of services and we've got really good coffee.
Can I ask, do you see an answer to the question, or the fact that the squeaky wheel tends to get the oil, we all know that, and because the DHB board and the chief executive and everything tend to live in the hospital or very near the hospital, that's the wheel they're going to hear squeaking. It doesn't mean that all the other wheels aren't about to fall off the train as well. And can you see an answer to the fact that you're just less visible?
I was thinking about that actually as we're sitting here, because your worldview is your worldview. Where do you work? I work in the hospital, and so that's all I see, which is all these specialists around me, or I refuse to use that term actually, hospital doctors. But it is about the worldview, and how do we get that part of that management out into the community. I know some of the doctors who run this CCDHB, and I should probably go and knock on their door. But my avenue of attack, if I need to attack, is to go through my PHO, and I write to my chief executive of my PHO going, Murton, sort this out. And he's like, another letter from her. But I think, it is actually very difficult. We've been squeaking for a long time, and I think until the DHB suddenly goes, well, actually, John Bonning can't cope with his ED department because it's just so ridiculously overwhelmed because there's no GPs in my area anymore. The DHB in mid-central, they have a huge crisis in GPs. The number of GPs per head of population is 56 per 100,000, and in Auckland it's 81. So in Palmerston North, they regularly send house surgeons out into the practice at the cost to the DHB. They support all sorts of things going on in their practices and make sure that there's training and everything else going on. And until the DHB suddenly start to realise that actually they are being overwhelmed because there's no service left, that's when things start to happen. And that's not good, because the patients have suffered by then. Yeah. So it just needs to start sooner. And I've done, whoever was talking about the fact that going around again and again and again, trying to work out a service to devolve it into primary care or whatever the service you want to transition, I've done it 3 times doing minor surgery stuff in primary care in Wellington. And the last time I did it, the plastic surgeon guy was with us. He swore, but he said, "You've messed with 100 hours of consultant time in the process of going through the service. And if you go back to planning and funding and do nothing, that is total crap." You know, what a waste of money. We could have spent it on the actual service. Yeah.
2 more questions.
Hello, I'm Kate Baddock. I'm chair of the General Practice Leaders Forum.
Yeah.
I'm also a rural GP. And just in terms of the burgeoning load in general practice, when I first started where I am, there were 4,000 patients. Now we have over 11,000. So it's growing, even though it's rural. And one of the things I would put out would be a plea. All the SMOs who are here, please talk to your DHBs about coming out into general practice. When we moved into our new premises some 10 years ago now, we have 20 visiting specialists, but all of them, despite the fact they've all got DHB appointments, all come in their private capacities because they cannot get clinical time freed up by the DHB to come out and hold clinics in their public capacity. But it needs SMOs to be saying to the DHBs, we want to be going out into the community, make it work, because otherwise we just don't see them, and it's incredibly frustrating. Echoing what Sam's been saying about actually bringing you out to the practices so that that's where you can actually see the people in their own communities is the first thing.
Who's a researcher here? Where's Charlie? New research, Charlie.
Yeah, exactly.
Just, you know, like with the psychiatrist who's going out into the Wanganui practice and with my one, I mean, there must be lots of people who are doing this sort of stuff, and it'd be really interesting to find out, you know, how much they deal with in an hour that then they don't have to deal with in their own DHB. It must save money. It must, yeah.
And the second thing is just a point of clarity with respect to the Auckland A&Ms. They are a breed unto themselves, but what they've actually done is they've combined general practices with the A&Ms in order to be able to enrol patients. Because, in fact, the A&Ms, by definition, aren't allowed to. But when you combine a general practice with them, then they can, and that's what they've been doing. So that's the second thing. The third and last thing is just a comment in that you're talking about salaries in general practice, and it's certainly true that younger GPs do seem to want to be salaried. However, they would like to be employed by other GPs. So some of us still have to be GP owners.
Yeah.
And we specifically asked the Minister at GPCME conference last week whether there was a plan to nationalise the primary care service, and the short answer was no.
I don't think that the country, you know, we're small enough, I don't know that we can afford it, but yeah, and the... I mean, there is a lot of evidence. You talk about access being about money, but it's not just about money. I mean, we can keep our services as low as possible. We can have our $18.50 fee. A lot of us discount fees to our patients a lot of the time, and people still don't come. I'll have people who I don't charge them any money because I use the long-term condition funding for them, and they still don't come because they can't get away from their work. They're worried about their employment. They've got someone else that they have to look after at home. Our poorest poor have got so many reasons for why they can't get to see us. It's not just about the funding. Yeah.
Okay, last question.
Hi, I'm Werner Paul. I'm an ex-rural GP and now a clinical leader of an A&M clinic here in Porirua. Thank you for the conversation, Sam, and bring something really important about what general practice, their role in the whole healthcare continuum. And I'm just realizing that there is a big vacuum in this conversation here today, which is the funders or the DHB management to actually connect primary care with hospital doctors. So the one thing that I want to underline what you said is that DHBs, we think of district hospital boards, which it's not. And so that concept, if there was an ability to bring the DHBs out of the hospitals into an equal playing field where general practice and primary care can actually take their full position as partners in the whole healthcare continuum, then there can be conversations about equity in salaries or remunerations for all health providers. So I think it's we're just missing something in the room. We're speaking to the wrong people at the moment. But it's good to have that socialization so that so that hospital doctors can actually understand what primary care doctors go through. Thank you.
Perhaps we should have them all come as undercover boss, and they could work on my reception for a fair day. I worked when I was a medical student. I worked through the DHB, and I used to work in ENT reception. That was terrible because everyone was waiting for the appointment, and they'd just stare at me, and I didn't know what to do. I worked in the store. I learned how to play. I could play cards with the lads down in the store. But I've worked all around the hospital in lots of different places, and I think actually seeing how the machine works is a really good way for people to see what's going on. And if we could get, if the DHB funder planner person came and sat in our office and with our practice manager or sat on reception or whatever for a day, it would be a real eye-opener to how much we deal with and how hard it is. Yeah.
Excellent.
So I'm going to be very naughty here because we don't usually speak. I'm Lloyd Woods, although people might know me as Mike. I just thought I'd mention the non-DHB sector because it is an area that the ASMS is involved in. It's a difficult area to be involved in. Most of our members who are GPs working as GPs, because we cover all of the doctors working in hospices, for instance, across New Zealand, basically. And we have members in ACC and we have members in New Zealand Blood and various other things. But for those non-DHB members working in GP land, they're generally working with the poorest patients in New Zealand. And yet, we've got collectives where they get some CME. Our doctors do get some CME. And we have got salary scales and so on. So it can be done. And we're certainly going to be doing it with a whole lot more of them, because as that corporatalisation comes through, it's going to become more and more necessary. So it is a work in progress, but we are engaged in that area, and we're going to be continuing to engage more in that area. Yeah. And I think in terms of where the money comes from, we've got to make, as we get better conditions for doctors, there will be more pressure on funding for that to allow that to happen. Yeah. And I think that's really important because there is a feeling that I get that GPs are seen as sort of the poor cousins. And I know there's a lot of frustration for some DHBs who feel as though they're not recognised as specialists, whereas of course they are. And so, we're working on all that stuff.
We sort of seem to sort of fluctuate between being the poor cousin and the blood-sucking private doctors. So somehow, I don't know how that works, yeah.
Excellent. So that concludes the last session today. I can see people getting up because they obviously have to go and get flights and things. But thank you, everybody. I think this has started some really nice conversations, which I know have been happening for a long time, and now it's about really putting those conversations into actions. Really echoing hospital doctors. Getting SMOs into primary care, fabulous. I've just started working in a general practice where we do this, and it is amazing, and it really encourages and empowers us to be able to manage some of those kind of murky in-between primary, secondary care patients, and really nice to have those face-to-face conversations and know who you're talking to, and so then when you phone them up, they know who you are and what you can manage as well. So, really echo that. GP's public health system too, indeed. Thank you, everybody, and yeah.